Hello and welcome everyone. You are listening to another live broadcast of MEDtalkx radio show. So we are broadcasting live on Pendle Community Radio, AWAS 103.1 FM. And it's also been broadcasted live on our YouTube and Facebook channel as well. So today's topic is back and spinal pain. Yes, there is a bit of a difference, but we will come across that during our discussion. So just be aware, this is all for information, raising awareness so that people understand more about their own symptoms so that they can be more in control with their journey when they interact with health professionals. If you have any questions, please do discuss it with your GP, as well as if there are specialist services involved. So there are a couple of numbers for you to be aware of. There is the studio number, which is 07522 723 455. And 01282 723 455. So over to you, Fahim.
Thank you, Behran, and a warm welcome and evening to everyone listening and watching wherever you may be. It's my great pleasure to introduce both our guests tonight. We have Mr. Shakil Patel, who's a consultant orthopedic surgeon specializing in back spinal surgeries based in Nottingham. And we'll be talking a lot about his work very soon. And also alongside Mr. Patel, we have Matt Faulkner, who is a physiotherapist and has been doing that for over 19 years now, both in NHS and private practice, and oversees 5 clinics mainly in the Cheadle in the Bamber Bridge area, and also is also AACP qualified. So he does use acupuncture as appropriate. So there's plenty to discuss there tonight. A warm welcome to you both.
Hi. Thank you very much, Shane.
Shakil, please let me start with you. You're obviously a spinal surgeon. For our listeners and viewers who aren't aware, can you give us a bit of a run through your daily week? What does a spinal surgeon do?
So I currently work at I'm working at the Nottingham Queen's Medical Centre, and my work essentially involves assessing and managing both children and adults with back-related problems. So anything from scoliosis in the pediatric or the children population to degenerative disease in the adults, back pain, disc problems, all from the neck down to the lumbar spine.
Excellent. And in terms of, obviously, you mentioned children and adults. What are the kind of differences that you see in terms of presentations then of both those caseloads? So
in terms of children, I mean, my predominant job title is a pediatric scoliosis surgeon, so I mainly deal with scoliosis in young kids. But the disease processes are very different from when you compare adults to children. Majority of kids that we see essentially may have a bit of back pain. The reasons for back pain are very different to that of the adult population, and most of the ones that I deal with essentially have a curve or abnormality to the shape of their back and the spine. In terms of adults, most diseases are essentially age-related changes and age-related diseases such as disc prolapse, lumbar spinal stenosis causing leg pain, and anywhere from the cervical spine down to the lumbar spine. But the differences in children is often either as a result of something they're born with or something idiopathic which is not clear. But in adults, it's generally as a result of an age-related process.
Great. And Matthew, can you tell the audience a little bit about the role physiotherapists have to play when it comes to assessing as well as managing back pain?
Yeah, well, it's a variety of things, really, I suppose. A lot of it's obviously the assessment, trying to get to the bottom of what actually is going on, because we can get quite a broad referral through from a GP, or especially from myself in the private practice, we have people that self-refer. So obviously the assessment and having the conversation and finding out what it is, why it is, and how it's affecting them. You can see everything, really. So obviously the assessment's key and all the questioning and all the rest of it, and how the patient views the back pain as well, because from what they say and what they do can be sort of 2 different things, really. And then we obviously through the assessment, if it's something physio can treat, so it can help with, which generally we can help with a lot of things, but there are obviously those occasions when there's obviously we have to pass over to the likes of Mr. Patel to sort them out, and then we can put them back together again afterwards, really. So yeah, it's quite a broad subject for back pain, and what one person views as back pain, another person won't, and it depends how it's affecting them and stopping them living their life, really. Yeah, I could probably talk for the next 50 minutes on that question, to be fair. But physio, the bottom line of physio is we can make it very complicated, but that just is to make us important. So essentially, it's if there's pain, get rid of pain. If there's tightness or lack of movement, get the movement back, and then strengthen them up and get them back into whatever level of function they want to be doing for life, really.
So I understand, Matt, you also have role to play in NHS as well as non-NHS related work. So do the cases present quite differently?
Yeah, they can be. I think from the experience of the people that come through the NHS, they tend to have had it for a little bit longer, maybe. And it depends on the GP and the NHS physio services, depending on where you are, as to how quickly they can get face to face with a physio. Which obviously with our COVID restrictions at the moment, that's changed again, because there's a lot of virtual physio out there, especially on the NHS. Us as private practices, we can do face-to-face treatment as long as we've been through all the protocols. But yeah, they tend to have had it for a little bit longer, so maybe a little bit more chronic when they're in the NHS. Private, they tend to have done it within the last couple of days, and they come and see you pretty quick. So from my point of view, the sooner you get it, or the sooner you get them after it started, the quicker you can get them back to less pain and more function, really. But yeah, that's some of the experience we've had over the years.
And Shakil, obviously coming to you, you did mention scoliosis, which is an interesting topic. Can you tell us a little bit about how the scoliosis presents and how you are able to surgically manage it if needed?
So it depends on the underlying cause. Now, scoliosis, essentially by definition, is basically a curve in the spine. And if you imagine that, everyone generally, most people have a straightish spine when you look at it front to back. So scoliosis is a curve in the, when you look at people front to back, say in the AP view, if you were to say, to use technical terms. So the causes, there's many causes for it. It could be, some children who are born with abnormal bones in their back, as opposed to being rectangular in shape, they're triangular. Some people, some children who have underlying disease processes like cerebral palsy or, other problems, they can often have some muscle imbalance, which can result in scoliosis. The most common, cause for scoliosis is in the adolescent population, so i.e. those greater than 10 years of age, where it's often termed adolescent idiopathic, which is where they have a curve in the spine. We're not quite sure what's the underlying driver or the underlying cause. And there's various different theories that are being proposed, but essentially they're all collectively termed as adolescent idiopathic scoliosis. And the main reason why we would intervene in kids like this is because as they tend to grow, the curves get worse with growth, and especially during the first few years of life, if it's early onset in young babies or young children, or in the latter aspect when they're going through their adolescent growth spurt. So that's one of the main reasons why we would intervene. An intervention can be anything from just observations with serial X-rays, or using a brace to try and prevent significant progression, to surgical treatment and correction. Other reasons why I would intervene in scoliosis, again, mainly referring to adolescent idiopathic scoliosis, are those children who are otherwise relatively well with no underlying problems, who have this curve in the spine for an unknown cause, to put it broadly. In these kids, one of the most common reasons why we operate is essentially cosmesis, because they're unhappy with their back. A small proportion of these patients may have quite significant back pain. So these are some of the reasons why I would intervene, but the predominant reason being in order to prevent curve progression as well as cosmesis in young girls.
Okay, thanks. And Matt, I want to come to one of your bread and butter presentations, obviously sciatica. It's commonly something that we go to the physio for to try and help. Can you tell the audience a little bit about what you as a physio do to try and manage sciatica and what it is really?
Yeah, I mean, the first thing I would say is I get a lot of people who refer to me or get told they've got sciatica, and it's not actually the true diagnosis. Is a lot of people who get a bit of leg pain or a bit of back pain and go straight to sciatica as the diagnosis. And then that brings up everyone's got a bad back, everyone's already got a story, the friend tells them it's never going to get better, and then they go to Dr. Google, and by the time they finish, their leg's going to fall off. So yeah, I think if it's sciatica, true sciatica for me is if it's not kind of all the way down the back of your leg and into your foot, then it isn't, or it hasn't developed into true full-blown sciatica. There's a wide variety of kind of nerve root issues and back problems, and one of the things that gets misdiagnosed for, from my point of view, is a lot of piriformis issues, there's a lot of muscle issues, there's a lot of muscle imbalances, tightnesses that actually a good physio that gets in there and assesses it can make a vast difference and settle the pain down and get them back to their normality again. Yeah, I mean, painkillers is a big part of it. We need the kind of the GP intervention from that, because I've gone around in circles with painkillers. At the time I was very kind of anti kind of anything really, but for me the painkillers should give you a window of opportunity to get yourself better. So it takes the pain off for you to get your movement back, and it's the movement that's going to fix you long term, if it's something that can be fixed by physios and stretches and doesn't need any kind of further surgical intervention really, I guess. But yeah, generally, especially NHS stuff, you've been through the GP phase, you've had your anti-inflammatories, you've had your painkillers, you've started taking your general advice, and then you get to me to sort of assess it further and try and develop a little bit more as to where it's coming from and why it's happening, and getting the patterns back to normal again, whatever normal is. I haven't met normal yet, so.
So Matt, so how would sciatica present? What are the key symptoms for to be wary of?
So, back pain, sort of diffuse sort of lower back pain, and then pain across into the glute, down the back of your leg, and into your foot are the main symptoms. So it's the leg pain, the nerve root pain, so the sharp pain, and it can have some altered sensations of numbness and some things like that down the back of your leg and into your foot, really.
So taking a step back, Matt, how do you prevent things like back pain? Well, what kind of advice?
If we crack that one,
$1 million.
Yeah, if we crack that, would never work again. I think the bottom line is we don't move enough generally. I think the modern world is a lot of sitting, it's a lot of computers, I'm desperately trying to have better posture than I normally have whilst I'm sat here. It's not the greatest if our posture is terrible when I'm talking about it. And that's something, picking up on the whole COVID thing and people working from home, certainly since we've reopened, because we were had to close for the best part of 3 months. People sitting on different chairs, different heights, sitting at desks, sitting on the end of the bed, trying to work on the computer and hunched over. We've seen a lot of people that have had mechanical back pain off the back of that. So just simple things you can do to move more, stand up, walk a bit. Just don't. If you stayed in perfect posture all day long, that can give you issues. That'll keep you tight. So just general movement. I know some people go to the extreme of setting an alarm every 20 minutes just to stand up and sit back down again. It just prevents things from getting stiff, gets the blood flowing, get the juices flowing, and will solve more problems than it's going to cause. So I think movement, basically, and it doesn't have to get complicated. It doesn't have to be, megally, not what I'm selling myself, but, megally important physio stretches. Just get moving is the basis of it. Would save a lot of problems and save a lot of people.
Here's a question for you, Matt. Do you actually believe that having a desk at a certain level, having special chairs, having a physio mattress and all this, do you think that makes any difference to back pain?
Do you know what the thing is? I think if you're investing in it, you're going to invest in yourself. So you're going to move, you're going to do the stretches, you're going to do the exercises, because you're spending money on an expensive chair, an expensive desk, and an expensive bed. The only desk that I've not done vast amounts of research, but thing is actually the standing desk, or the desk that can change height. And I think that, because you're moving with a different height and you spend some time standing, you spend some time sitting, is important. I think there is some ergonomic stuff around sitting. Certainly neck pain, the height of screens and things like that. I think that does have an effect, because it's something you're going to do for hours at a time through the week, through the year. So anything you're repeatedly doing, if you're doing it slightly off, is going to have a detrimental effect on you. So no, I don't think all the expensive stuff. I think there's a lot of shiny things that people are selling to make a lot of money out of, and I'm not convinced that they're going to be the magic bullet. I think that the cheapest thing and the easiest thing is to move more, and that would solve a lot more problems than a very expensive desk would. But I don't work for anyone. There's no sponsorship, so we're all right.
Expensive desk costs money. Exercise takes a lot of effort.
Well, yeah, exactly. That's the problem. And people like to think, well, if I'm throwing loads of money at this, it must be better, and I can blame someone else when it doesn't work. I think there's I've certainly noticed it in the last 5-10 years, that people not wanting to take responsibility for their own bodies, and it's easier to go and say, well, it's their fault, or I'll go and see someone who, I'll have an injection, or I'll have an operation, or and that's going to fix it. But when you say, well, actually, if you do these stretches, you can avoid that, it's like, well, I haven't got time. And I do get a bit frustrated some parts of physio profession that you'll go and see, and I'm sure you've worked with physios in the past that give you 3 sheets of physio exercises, and someone sits there and thinks, oh, I've got to give 25, 30 minutes to that. And if you get told that, you can't always fit it into your day. So for me, from my point of view, I don't give more than 3 exercises, really. There's no strict, you've got to do them at this time. It's got to be something that the person's going to buy into and do at some point. It doesn't really matter for me when they do them, as long as they actually do them. And then you hope off the back of that, the more they move, the better they feel, and they buy into doing a bit more exercise.
So a bit of smart goals there, Matt.
So something like that.
I think it's really important. I think you know which patients are going to do well with exercise and activities. Yeah. You get 2 groups of patients. You get those that are really engaged and are keen to improve their quality of life. Because as Fahim and you and even Matt alluded to, it's all about improving your quality of life, your comfort, and your function. So you get one group of patients that are really engaged, really gonna, make it work, and you tell them, look, you need to exercise, and they're very engaged. You get the other group of patients where that giving them advice that you really need to get an exercise bike, or you need to do some aerobic fitness activities. Sometimes I think to myself, how am I going to sell this treatment which I know is going to be effective to this patient? And sometimes when they come in with their husband or their partner and they're really big, you think, this guy's just going to get up and deck me as soon as I say anything. But the natural response is, I can't move. How do you expect me to get an exercise break? How do you expect me to do X, Y, and Z? Right? Yeah. And they're always looking for a surgical problem or someone else to address their problems as opposed to taking responsibility. And you know that these patients are going to do really bad because often they're chronic patients. They've seen multiple health professionals and they've been given mixed messages. Whereas if they were given, a concise set of exercises, if they were told that, look, it's all on them, they really have to engage in these activities from day one, maybe they would have had a better outcome.
Yeah. Or they wanted the MRI scan that's going to show them exactly what it is. And we could go around in circles with that conversation.
I think you've alluded to an important point, though, Shakil, about responsibility. And it's difficult. And I think, to be honest, we'd probably need to do 2 shows just on that topic. Because there's lots of cases where people do need to take ownership, but there may be certain elements, whether it's physical or psychological, that seem to come in their way, and they go in this state of learned helplessness, which I think we have to recognize and try to support them through it.
But from my point of view, it's how you educate that patient or whoever, or a family as well, as to what they've got and why they've got it. Because for me, it doesn't matter. I could give them the best exercises in the world, but if you don't understand why it's going to help them, what we're trying to achieve by doing it, I wouldn't do it. Nobody would do it. And that I think sometimes we miss a little bit in healthcare. We don't, because of timing, because of everything else. And I'm fortunate because I work privately, I can spend that extra bit of time with them and say, this is why you're doing it. And then when they know, and it will hurt, and this is why it's going to hurt. And then it cuts out some of the excuses when they get home and go, well, I did them, but it hurt, so I stopped doing them. But if they go home knowing that it's going to be a bit more difficult, and unfortunately, I can give on my own rights, well, phone me, text me, either me, it's fine. And we can talk you through, and I can tell you that's right, wrong, or indifferent. And then thankfully we get a little bit better buy-in. But the unfortunate thing, I guess, you learn with healthcare is you can't always fix everyone.
Yeah, I want to move away a little bit from the theoretical stuff to more practical, Shakil, and let's go down to some details. Obviously, in terms of cervical spondylitis, that's quite a common condition out there for the public. Do you mind just telling people a little bit, Shakil, about how that presents and what you think the best way to manage that would be?
So first of all, what I would strongly discourage people from doing is using these technical terms, right? So just to use a term that you've used, Fahim, cervical spondylitis. Spondylitis, by definition, means inflammation of the spine, okay? And I think what you're alluding to is cervical spondylosis, which is essentially degenerative changes of the spine. So 2 very different things. Now, one of the problems is once individuals are given a term, or they're told that your MRI scan, your X-ray shows cervical spondylosis, then ultimately what they do is they just hold on to that definition, they hold on to that diagnosis, and they don't realize that actually that's a normal thing. So just to, if my understanding is correct, right, the spine matures up to the age of 20. After the age of 20, it slowly, undergoes age-related changes. Okay, and these age-related changes, in the cervical spine, which is the neck, is cervical spondylosis. In the lumbar spine, it's lumbar spondylosis. Okay, and often when individuals, they come in with back pain or neck pain, they go to the GP. You'll assess them thoroughly. You maybe send them for an X-ray and an MRI scan, and then the MRI scan report will come. Some very clever radiologist has said, "Oh, this patient has cervical spondylosis." You tell the patient they've got cervical spondylosis, and then ultimately they just hold up to that diagnosis and assuming that it's a pathological condition, it's something abnormal, and that's responsible for the symptoms and the pain. When in fact, it's not true. So when I see my patients in clinic, often those patients that you've tried to manage who have chronic pain, either sciatica or back pain or neck pain, and they come wanting an MRI scan. The problem is if I can't in my mind, attribute something, their clinical symptoms to what I'm going to be looking for in an MRI scan, again, an MRI scan is not going to be helpful. Because and the rough figure that I give, and there is evidence to support this in elderly patients, that patients over the age of 50, if I get 100 people off the street over the age of 50, 50% of them will have changes, but not all of them will have symptoms. And likely those over the age of 80% of them will have changes on the MRI scan, but they won't have symptoms. So if I can't, in my mind, attribute the symptoms you're having to a definite diagnosis, then getting an MRI scan for me is pointless because I don't have a surgical target in my mind, and we have a mantra: we treat the scan, so we treat the man, not the scan. Okay, so to answer your question, cervical spondylosis, essentially patients can present with varying problems, ranging from neck pain, but essentially as spine specialists, and I'm sure Matt will agree with this somewhat, is that what we're good at treating is nerve pain. Okay, so when it comes to the back, the neck, these are really complex structures. There's lots of joints, lots of tendons, lots of ligaments, lots of discs, lots of nerves, and any of these can be pain generators. When we get an MRI scan, we're looking for treatable causes, i.e. compression of a nerve. If someone has cervical spondylosis, for example, and they have radicular pain, that's pain going down their arm, or they have lumbar spondylosis, for example, and they have sciatic type pain going down their leg, then there's effective measures or methods to treat this. But if their predominant problem is neck pain or back pain or low back pain, then essentially the treatment for this is not, I'm not saying it's not surgical. There are indications for surgery, and the aim is to identify the red flags which we touched on in the GP teaching session, where if they've lost weight, and essentially the red flags are things which create awareness or alert a clinician to things that may be significantly wrong, such as infections, tumors, fractures, etc. Once we've excluded all of this, then the neck pain or back pain is all around rehab, physio, exercises, self-management mainly, and pain control. But if they have spondylosis, which causes radicular pain to the arm, and again, most common case cause of radicular pain is a disc prolapse, and most disc prolapses, 70% resolve spontaneously by 6 weeks, 90% resolve by 3 months. Okay? So in the majority of cases, we don't even need to intervene. We just need to take pain control, stay active, maintain fitness, activities, etc. And nature, is such that things will just spontaneously resolve. Once you start seeing a spine surgeon, then unfortunately things are downhill from there.
I want to educate the public as well, and there's another important topic, Shakil, I'd like you to just talk about, and that's something called Cordura equina, which I'm sure all of us will have heard of, or Latin for horse's tail. Again, I know for a lot of people with back pain, they're warned about these sort of symptoms. Shakil, can you tell the public why this is an important symptom or condition that people suffering with back pain need to be aware of, and the implications of missing it?
Okay. The Cordura equina syndrome is occurs where some people may have a large disc prolapse or for whatever reason, which compresses the nerves of the lower part of the spine. And as a result, patients often present with significant low back pain, with pain going down both legs, and problems with the function of their bladder in terms of urination, and maybe some numbness around their bottom end and their back passage, and potential problems with the sphincter, i.e. the muscles which control urination and defecation, or when you go to the toilet, for example. Now, the reason why it's really important, because if this is missed, and often it can have long-lasting consequences, such as urinary dysfunction. So they have to have a catheter in, for example. They have dysfunction with emptying of their bowels. They often get really constipated, have to have manual evacuations, laxatives, etc., sexual dysfunction, and maybe weakness in the legs or in their feet. Okay, so but the proportion of patients who actually present to us in the spine unit with cauda equina syndrome, who actually have cauda equina syndrome, is very small. So I think, and don't quote me on the figures, but I think we're looking at about 10%. So 10% of the patients are referred to us with query cauda equina syndrome, who we investigate and assess have actual cauda equina syndrome. The reason why it's a hot topic, because it's a significant impact on an individual's life. Okay, it affects some people have chronic pain as a result. Now you can imagine being functional, being healthy, having a job, and being an important member of society, contributing to society. Having a good family, having good relations, to then being in a point where you're dysfunctional, you have significant pain in your legs, you've had you've had an operation, or you may have had an operation, you lose control of your bladder, you lose control of your bowels, you lose sexual function, affecting your family, affecting work, and it's not a good outcome. So therefore, it's important to have awareness of it, but that at the same time, the number of patients who actually present with it, is relatively small. Okay, but generally, whenever you see, or whenever individuals or doctors see patients who have a disc prolapse, they're often given these red flag signs. So red flag signs are concerning symptoms such that if you develop weakness in your legs, if you develop problems with your bladder function, if you have an accident when you're passing urine, if there's numbness around your bottom end or around your perineal region, these are all concerning features. And if these do develop, then present yourself to A&E. And again, these are the patients who only 10% of which we identify as having cauda equina syndrome. But we'd rather over-investigate individuals and exclude this than to miss an individual who may have it, and essentially, and miss that diagnosis. In addition to the impact on the individuals, which is massive, and I think that's the greatest impact that I'd be concerned about. Missing it has great medical legal consequences. There's been a big payout from the NHS. Okay, so from a doctor point of view, the main reason why I wouldn't want to miss it is because I wouldn't want it to have a negative impact on all these aspects of an individual's life, which we can't really put a monetary value to.
Thank you.
So Matt, obviously we've talked about specific disorders, but I'd like to get your take on what are the actual risk factors for back pain, and what kind of conditions are rehabable, and what perhaps you perhaps struggle with, not specifically yourself, but just physiotherapy.
Yeah, where do you start with what I struggle with? Don't play rugby, it's bad for you. Yeah, it's quite a big topic, really. And I'm always probably erring on the side of optimism when it comes to physio, that we can, if we can't fix everything, we can certainly impact change on pretty much any condition that walks through the door. Because I think I've been quite fortunate in my career. I had quite a sort of eclectic career and worked with a lot of some people who've had quite severe kind of life-changing injuries, and with determinations, with consistency of effort, they've come back and they have increased the function in life. It might not be perfect, but they can do what you can always do a lot. And I do get in my private clinic people who have had back pain for becoming 15, 20 years. They've been passed from pillar to post. They've perhaps got to the point where they're just taking medication and painkillers every day, and they can't really see a way out of it. And you can impact change with them as physio. It takes time. It takes a lot of education. It takes them to buy into it, and that is a big challenge. I mean, any condition can be improved. I mean, simple back pain or mechanical back pain, or whichever buzzword you want to give to it this week, because it's changed probably 1,000 times over the last 20 years of my career. It is moving better and moving more. It doesn't have to be more complicated than that. We make it complicated because we want to try and be important or sell something. But for me as a physio, for a message for the general public, and I think all this COVID stuff has been a crazy time, but one thing's been quite nice for me to see and is people getting out and walking more, just getting out and moving and doing stuff, because they've realised they're stuck at home, they're stuck on a desk. Whereas if you're in the usual rat run and in your usual routine, you're up breakfast, sat down, in your car, sat down, at your desk, sat down, and then the vice versa on the way back. So much as I'll do myself out of a job as a physio and won't get people coming in the clinic if they fix themselves, but that's the ideal solution, isn't it? None of us really want to have anyone to come and see us because we want everyone to be well. So it starts with movement, whatever movement that is. It doesn't have to be perfect. I think we get fixed as a society and fixed generally on it's got to be a magic cure, it's got to be magic one exercise, it's got to be magic this or a magic that, and people sell that because that's what Facebook does and influencers do and all that stuff. But I could swear it's a lot of rubbish, to be honest. It's just, start with what movement you can do, and then slowly start increasing as the pain gets better or your movement gets better. And obviously a good assessment from a physio to tell you which exercises to do, but it doesn't have to be complicated. Just get moving, really. And pain, the other thing to say, I mean, we could probably have another podcast on what pain is, but pain, from my point of view, the pain that people get with back pain isn't always because there's a problem. Pain isn't just because something's broken and needs fixing. It's because it's tight. It's because it's not quite moving right. And that pain is an indication of that from your subconscious, not that something needs fixing. And that's something that, is a big part of me with your chronic pain. People are saying, well, why is this pain? It's a reaction to a perceived threat, not because something's not working right. And then once they understand it's going to hurt, at least they go, well, I know I'm moving, I know it's hurting, but I'm not getting worse because of that. That seems to help and get people moving again.
Yeah, I think, as you said, pain is a huge topic. We are hopefully due to cover that in upcoming weeks. But as you alluded to, lack of activity, fitness level. But the other thing is about weight. Now, low BMI, high BMI, is there an optimum weight to be able to...
Well, yeah, I don't take my own advice on that, I don't think. Where do we go with BMI? Because I don't particularly personally believe it's a perfect measure of weight or anything as far as, but it's the one we've got, I guess. Because obviously, like I say, I've played a lot of rugby. I know a lot of people that have got pretty high BMIs, but they're fitter than the average. Weight obviously impacts. If you're heavier than your frame can carry and should be, is going to put more pressure on joints and life in general. Obviously, people that are overweight and more weight on the front, it will change your center of balance. It'll change and it'll put different pressures on how you move and all the rest of it. And it's got to have an impact. And one of the things from me as a physio is having that honest conversation with people. It's a difficult one to bring up sometimes because not everyone wants to address it. It probably helps that I'm not skinny because I don't get there. Well, it's all right for you. But it is something that people need to be honest about. And unfortunately, in society, we do seem to be getting bigger rather than smaller. So, it's something that needs addressing, really, I guess. But how you address it is another matter, isn't it?
Yeah. I think what's important is recognizing that there's we all know that there's a biopsychosocial model to back pain. Okay, but there are a small group of patients who have genuine reasons for back pain, i.e., they may have significant scoliosis as an adult. They may have significant degeneration in the discs, or pain generators. Some patients, may have a cancer in their spine, and these things need to be recognized and identified, and then directed for treatment. But I think what we're alluding to here is if you look at back pain generally, non-specific low back pain, so 80% of patients who have back pain do come under this umbrella category of non-specific low back pain, where they have back pain, but there's no obvious identifiable or treatable source for. And again, the MRI scan isn't necessarily helpful because, as I said, MRI scans will show pathologies. The older we get, the more pathologies there are. They may not, be, represent the patient's source of pain. So I think everything that Matt's alluding to here in terms of exercise activities, getting patients to engage, etc. This is more so for patients who have non-specific low back pain. Whereas again, despite the fact that we say that actually surgery is not necessarily a good option for back pain, there is a subgroup of patients who may be who essentially may be suitable for surgery in order to treat their pain. But again, the problem with surgery for low back pain is that there's significant complications associated with it.
Yeah.
So Shakil, isn't just kind of carrying on the osteoporosis torch? How much of an issue is it for you?
It's a massive issue. I think we're seeing lots and lots of patients who have vertebral compression fractures or osteoporotic fractures. As we're all aware, more common in the elderly, postmenopausal women, etc. And the problem with having an osteoporotic fracture is once you have one fracture, then it's a risk factor for having further fractures. And there's evidence to suggest that actually having osteoporotic fractures reduces an individual's life expectancy, similar to that of patients who have hip fractures. Every week on our list at Queen's, we have patients who've had osteoporotic fractures, who are in significant pain or find it difficult to mobilize, that we inject cement into the vertebra in order to try and give it some stability to control their pain and get them to mobilize, get them to a decent function, and hopefully their pre-fracture level of function. And I think with increasing age, it's definitely a problem that we're seeing more and more, and the treatment for it is very, very difficult. So often these patients have comorbidities and lots of their health problems. We're very lucky in Nottingham that we work very closely with our elderly healthcare physicians. And they often see these patients, they identify those that are finding it difficult to mobilize, they optimize their pain control really effectively, and then essentially just filter out the patients who they feel would be suitable or who may do well from a vertebroplasty. So we work very closely with them, and they're actually an asset to our department. But this problem is just going to get worse and worse.
Shakil, you mentioned obviously Nottingham, and Nottingham is well known for its A&E department and trauma and these sort of things. I'm wondering if you liaise much with the neurosurgeons in cases, Shakil, and if you can maybe enlighten the audience slightly as to when you have joint cases and maybe the sort of traumatic type of back injuries that may present to you at a large hospital like Nottingham.
So we, in our department, we have two spine surgeons, Mr. Sagai and Mr. Equina, who are both trained. So in order to become a spine surgeon, you can either go by the neurosurgical training route or the orthopedic training route. So two of my colleagues have come by the neurosurgical training route, very good spine surgeons, but essentially they dive into the neurosurgical component of it. So we do. So if need be, we do work with our neurosurgical colleagues or a separate department, but because we have colleagues who are essentially competent and very good at what they do in terms of neurosurgery as well as spine, we often don't have a need to work with our neurosurgeons from a separate department per se. In terms of trauma, when it comes to spinal trauma, essentially the aim is just to if they come in with a significant fracture to the back, the aim is to stabilize the back and rehab. So neurosurgical treatment doesn't necessarily come to it. The neurosurgical component comes in patients who may have intradural tumors or significant pathologies within the spinal cord itself. And again, within our department, we're very lucky that we have really good, two really well-trained, competent, experienced colleagues who can essentially deal with this problem.
Okay. And earlier in the year, obviously, when the COVID pandemic started, and Shakil, obviously your job is quite hands-on. Can you tell us how the remote consultations or perhaps the work changed for you in actually the case mix, and what things perhaps got deferred, and how your actual day-to-day job changed from, say, March onwards?
So when we were hit by the pandemic initially, because of the anticipation of the hospitals being inundated with COVID patients, we stopped all elective surgical practice. So we stopped our planned elective operating. And because in order to reduce the transmission of COVID because of lockdown, we essentially started doing lots of consultations over the phone. The problem that we face is that as a result of that, most of my patients who I see who have scoliosis, I often have to, who have to have X-rays to see whether the curves got worse, etc. Weren't having their radiographs. They found it very difficult to practice at that point in order to meet the needs of our patients. But I think, once the dust settled, it picked up. We started doing more phone consultations. And actually what we found is a lot of our patients, it's important for the initial consultation, just so you can meet the patient can meet you, put a name to a face, etc., and form that rapport with the patient. It's important to have that face-to-face. But after that, providing they've had an X-ray for those that were, that are under surveillance, actually, you can actually do everything over the phone. So it's reduced the number of patients coming into hospital. It's better for patients, I think. You don't have to come, take a day off work, find car parking spot, pay for a bloody car parking spot, and the rest of it, right? And they come, have their X-ray, go home. There's no prolonged waiting, etc. They just, we tell them that we'll call you either in the morning or the afternoon. So likewise, I think that's improved flow. We did restart our planned operating, as once things had settled down, and we were operating back to about 80-90% capacity up until recently. But now, because of concerns with regard to the second wave, that's now reduced down, again, with an anticipation that, maybe our ITU service is going to be hit, our anesthetic colleagues are going to be redeployed to look after these COVID patients, there's going to be staff sicknesses, etc. So in that anticipation, I think, the elective practice has taken a hit as a result. But we found new ways to work. We're making, these are difficult times for patients, but, for us as well. And I think we're just looking at different ways of working, just as you have in the GP land, more and more. So virtual consultations and things like that.
And I guess the same question to you, Matt. Well, what's COVID meant to you? Because I guess you can't really social distance.
No. It's made me realise I won't pass junior school English. I think that's from my homeschooling. Obviously it was the 23rd of March. I think was we had to shut. We had to close all our clinics. And then we got back to practicing probably end of June, beginning of July. One of our clinics isn't open yet, so we're back and at a reduced capacity. Obviously, we're following kind of CSP guidelines, Department of Health England guidelines for getting them back into practice. All the PPE and all the rest of it. It is virtual first, so it is a phone call and a conversation and. Go through the COVID screening things, and then we are allowed to get back. If everyone's happy, then we get the face-to-face treatment, and we can crack on and get them better. Really, I mean, there is stuff you can do face-to-face, or over sort of virtual rather, and Zoom and things with a physio point of view. But I think I don't know, maybe because I'm a bit old, I'd much prefer seeing them face-to-face and getting my hands on them, and we can sort of get a bit more testing and get a bit more down the line as to what's going on. And then maybe there's a mix. There's a case of having a mix of management. Once you've seen, you've had your hands on, then you can do checking up on exercises. We send quite a few exercises online on via email or whatever, and then we can go from there really. But it's been interesting, I think. I'd have some work with Joe Wicks if I met him, I think. But other than that, it's been a great time.
We are actually getting lots of questions through. I'm going to ask. I'll leave it to both of you, Matt and Shakil, who wants to answer. So one of the questions is: when I wake up in the morning and get out of bed, I can feel some pain in the back for a while, but throughout the day, this pain is relieved without any particular exercise or treatment. Can you explain why this is, and should I get this checked further with my doctor? There's no reference to age or gender. But
who's going for this then?
So for me, if you have, if again, as you refer to, it depends on the age, depends on the gender. Now, if you have a bit of back pain in the morning, which gets better with activities, no issues, then I don't think you really need to investigate that any further unless the pain's getting worse. One of the red flags, as I'm sure you're aware, is pain which lasts for more than 30 minutes in the morning and then eases off throughout the day, and that's just more of an inflammatory component. And so, if you're a young female, you may be concerned about some form of arthritis. If you're a young male, again, the concern there is ankylosing spondylitis. So there's lots of other factors are involved, such as age, sex, the duration of pain, its response to painkillers, etc. I would say if it just lasts for a little while, you're functioning well, no problems, I wouldn't really worry about it. However, if the inflammation and if it's really sore and really stiff and it takes at least about half an hour for you to shake that off in the morning and then it's okay throughout the day, then maybe you might just want to go to your GP. You can do some simple blood tests just to rule out any inflammatory problems.
Great. Matt, just one more question, since Shakil kindly answered that. Can stress be a factor for back pain or not?
Yeah, no, and I think it's something that we don't perhaps give enough credit to be honest. I think certainly for me in my practice, sort of as I've developed as a physio, it's something I think we've become more aware of the sort of the psychological side of life and how it affects you kind of physically. And it's not something I think we've given enough credit to over the time. It's not just the physical thing; it's your mental well-being and how your body then reacts to pain, or your subconscious then reacts to pain, and how it impairs your function is massive. I think it is quite important, really, and it's something I don't think we entirely understand it at the moment, but it's definitely something that's we're growing in understanding with it, and how your mental health affects you physically is a big part of getting better from these things, really. But that's something like from my point of view, you pick up in your assessment and how they're talking and how you kind of discuss the problem that you've got, really. And it can flow from there. But yeah, it is a massive part of back pain.
Shakil, obviously you talked a bit about this concept of spondylosis, and obviously you deal with scoliosis as well. Obviously, for people who aren't aware, there's also kyphosis and certain things that can lead to that. Are you able to expand a bit more on what kyphosis is, and then it's all rounded off, the whole concept of kyphosis and scoliosis together?
Okay. So one of the functions of the spine, as well as to protect your spinal cord, is to keep your head balanced on top of your bottom, so that you can walk, you can maintain a horizontal gaze and look forward and function with minimal energy expenditure. Okay. So when you look at someone front to back, ideally the spine should be straight. When you have a curve in that dimension, then that's referred to as a scoliosis. Now, everyone naturally has some form of kyphosis and has some form of lordosis. So kyphosis is a forward bend when you look at someone from the side profile, and that often happens in the thoracic spine, so the upper spine over here. And then you have a lordosis in the neck, in order to keep your head up. And then you have a lordosis in the lumbar spine. And all of this balances itself out to keep the head balanced on top of the bottom. Some people may have an exaggerated kyphosis, and I'm sure most of us have seen elderly folks who are walking who have a really, really hunchback deformity to the spine. And often, the cause for this, as we referred to earlier on, is multiple osteoporotic fractures. Once you get one fracture, they lean forward, they get another fracture because of the forces of the spine, and they get multiple fractures. So that's in the elderly osteoporotic group of patients. In the younger patients, so, the young men, for example, they can have a condition called Sherman's kyphosis, where there's some abnormality in the disc and the vertebral bodies, such that they're not perfectly rectangular, but they're slightly wedged, and as a result, they have increased kyphosis to the thoracic spine, and that can present with concerns with regards to cosmesis or increasing low back pain or pain around the kyphosis. And these can be addressed, and in the group of patients where it is a problem, they're treated surgically and corrected. But the problem group of patients are the elderly patients where their bones are very osteoporotic. But in order to correct these, it's a big, it involves a big operation, with multiple screws, operations around the spine, with risks of potential paralysis, etc. And often the bone quality isn't that great. It's a bit like hanging a heavy TV onto plasterboard. It's something you just wouldn't do. Okay, but in a group of patients, and again, we work very closely with our medical colleagues, who optimize bone health, etc. These operations can be done for those who don't have much comorbidities and who are otherwise healthy. But again, we know from the evidence that these patients do have a high complication profile, and anything up to what's been published, 76%. Okay, so surgical treatment in the elderly group of patients. Okay, in the younger group of patients, complication profile isn't that great. But essentially, everything we do to the spine when we're treating these conditions, we're stiffening the spine. Okay, and stiffening the spine, in my mind, even though that's what I get paid for, isn't that great of an option if it can be prevented, because you're using that mobility of the spine. And essentially, when you stiffen the spine, you just transfer that movement to the adjacent segments, which if they're taking that extra slack that other parts of the spine should be taking, they're just going to get worn out more sooner. Okay, so does that answer your question in terms of kyphosis?
Yeah, no, absolutely. And I want to talk about a core topic again with you, Shakil, and that is spinal cancer. You did mention that at the beginning, that obviously how you can get cancers in the spine. And can you tell a little bit for the audience, is that the primary, or is you most commonly seeing it as a secondary? And what's the surgical treatments that you sometimes do? And can you treat all of the cancers in the spine?
Okay, so most commonly, the cancers that come from of the spine are those that are spread to the spine from other sources. So, for example, the breast in the females, the lungs, the prostate, the thyroid, and the kidney. They're the most common ones that metastasize or spread to the spine. Primary spine cancer is quite rare, as is primary bone cancer is quite uncommon. Again, there are a small subgroup of patients who do develop that. Now, once an individual has a cancer which has then spread to the spine, if the cancer is localized to one area, for example, if you have breast cancer, then that's localized to the breast. If you have lung cancer, that's localized to the lung. These are potentially curable targets, okay? Whether it be with surgery, plus or minus chemo, radiotherapy, etc. Once it's spread to the spine, which most of the cancers to the spine are those that have spread, then essentially the cancer seeded to the rest of the body. Now it depends. If there's just often a small vertebra involved, then we can potentially consider what's called curative surgery or curative treatment. But in my eyes, it's not always curative, because if it's spread to the spine, it's spread elsewhere, although it may not have manifested by that point. Now, how do you address this? It's very difficult, because it involves breaking bad news to the patients that they've had a cancer which has spread to the spine, etc. But essentially, if we look at the purpose of the spine, which is to maintain, as I said, the head on top of the bottom, to prevent deformity, to maintain nerve function, if any of these aspects are compromised, then we look at maybe surgical intervention. But that surgical intervention has lots of factors that we need to consider before actually we consider operating or offering patients an operation. And factors such as how much longer do they have to live, what's their disease burden, what's their quality of life at the moment, what's their how well are they going to tolerate an anesthetic, and how aggressive do we be. There's lots of these factors involved, and often what's involved is a multidisciplinary discussion with our oncology colleagues, who are essentially going to be treating them systemically, and us trying to treat them locally, because what we don't want to do is expose them to a big operation on their spine, okay, which again often involves putting lots of screws, rods in, and decompressing the spine to maintain the nerve function, to ensure that they still are able to walk, maintain the bladder and bowel capacity, etc. But if someone's got a life expectancy of 6 months and it's going to take them 3 months to recover from this operation, maybe that's not a good idea. But if they've got a life expectancy of 12 months or more, then that's when we'd actually consider doing significant surgical treatment. But even those individuals who don't have a significant life expectancies, for example, they may have 6 months. If they have significant pain, what we can often consider is injecting that vertebra with cement, and that often helps relieve the pain as well. So there's lots of things that we can do, but often these patients are referred to us by our oncology colleagues, and it involves a discussion with them to see what's the best form of treatment for this patient, as well as discussion with the patient, because at the end of it, you're providing treatment to try and improve the quality of life, maintain their function, and whereas their prognosis and life expectancy may be significantly compromised. Okay, so it's not the decision is very difficult, and more and more we're seeing younger and younger patients who are presenting with cancer that spread to the spine, and that often gets emotions and everything attached to it as well, because there's some patients are my age. Okay, but it's something that we're seeing more and more commonly, and I think the COVID's made it more difficult, because some of these patients may have been pre-COVID, may have been identified sooner, with treatment established sooner, low risk of. I can't really demonstrate any stats with regards to this. But I think as a result of COVID, because of the concerns that some patients may have going to the GP, going outside, the whole lockdown, maybe difficulty seeing the GP, difficulty getting hospital appointments, some of these patients may, as a result, present late with cancer significantly spread as a result, and it's often very difficult treating these patients. And then I think at the time of the first wave, there were concerns with regards to chemotherapy, well, not necessarily radiotherapy, but chemotherapy, we're immunocompromising these patients, where if they get COVID, I think we're a lot more, broad now, our shoulders are a lot more broad, we understand COVID a lot more. So I think, we're trying to ensure that these individuals do get their systemic treatment, which is far more important to control the overall disease, because anything we do in the spine just controls it locally. Does that explain?
Absolutely.
Answer your question?
That's great.
Yeah, thanks, Shakil. That's a pretty comprehensive answer there. But I just wanted to say thank you to all our viewers and listeners. We've got a great deal of questions coming in. If you like what you've heard and believe in our previous episodes, please do subscribe to our YouTube channel. We're running short of time, but there's a couple of questions I just wanted to ask you, Matt. Maybe we've got one at least. But this idea of core strength and developing your back and your muscles, is there any truth in terms of whether it can be preventative for back pain?
No, I don't. There's a lot out there that your core's going to fix everything, which I think you probably find it very difficult to actually isolate and switch on the muscle that they tell you you're going to be switching on when you're doing certain exercises. I think there's a lot of buzz and a lot of stuff around it, which I think we're kind of coming around to thinking actually it's not the specific core as such, but actually moving better, stretching, doing the actual exercises and learning to breathe as well is quite important when it comes to back pain, and understanding why you've got the pain and moving. I think there's a lot of misinformation about core stability, to be honest. I mean, we as a clinic, we run Pilates classes, and I think Pilates classes and Pilates as such is really good because you learn to move and you learn to switch muscles on, or you learn how to control your back and your muscles in a better way. But core, there's a lot of hype around it. It's probably the nicest way of putting it. People are really worried about switching on a certain muscle, and they think they can isolate it. And personally, they're better than me if they can. And I really don't think it's the be all and end all. I think it's no, not really. It's another way of saying something else.
Oh, great. Yeah. We've got a couple more questions coming in. So this is from Sam K. So he kind of reflected saying that he had a patient once, first presentation was cervical spine, and cancer was a late presentation, was not picked up. How do we do this and when? So this may be more appropriate for yourself, Shakil.
So I think what's important is looking at the red flags. If a patient who is functioning well, who has spontaneous onset of pain, which is unremitting, not responsive, getting worse, night pain, if they have neurological abnormality associated with it, then I think these are all red flags and should alert a clinician to maybe investigate this further. Okay, and it may be with simple measures like X-rays or refer on MRI and etc. But it is quite challenging, especially when you have patients who have chronic low back pain, and it's really not easy. But when you miss things like this, it's a big hit to you as a doctor, as well as a big hit to the family. I can speak from personal experience from my father, who almost had an undiagnosed bowel cancer from due to lack of investigations. Fortunately, I'm a doctor, so I pursue this further. But the answer to the question is, you have to look at the red flags, and the red flags isn't absolute. You will get some patients who don't fulfill any criteria, but if they're functioning well, they're normally working, etc. They develop random onset of pain's worse at night, it's mechanical in nature, maybe have some neurology. These are things that you would want to investigate further, or maybe refer for further assessment.
Great.
Yeah, Matt, we are coming near the end of the show, but you did mention acupuncture. Can you tell us maybe how acupuncture can come into some of the treatment, or maybe other complementary therapies perhaps, or things like manipulation and the full arsenal of things, Matt, that you can offer?
Yeah, I mean, acupuncture, I think again, there's a lot around acupuncture that if you believe in it, don't believe in it. For me, it's not a cure-all. It's not the thing that's going to fix it, so to speak. I think it's a great kind of addition to treatment, really, for helping to modify pain, help get the pain under control, and it then for me gives us an opportunity to then get the exercise in, get you moving better, and it's the movement that's going to fix the problem in the majority of the cases that I can see that physio can fix. Yeah, I mean, there's no one size fits all for me from a physio point of view, which I guess I've kind of learned over the years. There are a few people that say that if you do these X, Y, and Z exercises, it's going to fix everything, and unfortunately, I don't think that's particularly true. But yeah, acupuncture is something for the people it fixes. It's amazing. For the people it doesn't touch, and I don't know why. We probably talk for another hour about that, to be fair. But I think it's always worth trying, and it can't do any harm. So yeah, it's a great thing.
Excellent.
Acupuncture is no longer recommended by NICE, right, for the treatment of back pain. So that's one thing, right? I think it's voodoo, okay?
Yeah, but voodoo for some people.
No, I do appreciate it. Again, even when you look at evidence and studies, there are a small group of patients who may have benefited from it, but when you group it all together, the evidence may not support it. I think in terms of back pain, I think what's really important is identifying the obstacles to recovery.
Yeah.
So I think the first individuals, like when patients have back pain, they're often going to come to their GP. They may see a physio, they may see a private physio, etc. I think it's all having a consistent message. Making sure that you rule out all the red flags and all the concerning features. And then once you feel like, okay, this patient comes under the banner of mechanical non-specific low back pain, essentially making them following a NICE guidelines, such as getting patients to manage their own condition, getting them to take charge, identifying those obstacles, for example, work-related problems. So we know that, if individuals who are working, who are unable to go to work, and their work's unable to accommodate them, this often doesn't really serve them well psychologically, socially, and that can often exacerbate their symptoms. Okay,
Yeah.
Likewise, if they're given negative messages, oh, you've got lumbar spondylosis, or they've had an MRI scan, it shows that, which really, in fact, doesn't mean nothing. You wouldn't go and tell a patient, oh, you've got grey hair, you've got a few wrinkles on your face. Okay, and that's essentially what lumbar spondylosis is. There's a few wrinkles in the spine, and it's no big deal, right? So trying to prevent medicalizing these patients, avoiding medical jargon, and once you medicalize them, once you say to me you've got lumbar spondylosis, a number of people I've had come to clinic say, oh, I've got lumbar spondylosis, doctor, this is causing my back pain. They say, well, no, that doesn't really mean anything. So, I want you to ignore what you've been told now. And then once they've given these negative messages, it's very, very difficult to unpick them, to try and get them on that trajectory of improving in quality of life.
Yeah, definitely.
And I think addressing these obstacles is really important. And I think if you do that properly, because we know that having a psychosocial model for addressing pain helps these patients, but no CCG funds this.
No. And I have to be optimistic with the way you speak about it as well, and tell them that you can get better from it, because they've been told, oh, once you've got it, you never get back, and then they live to it, and and it is tough when you've got back pain and everything hurts every time you do something. But for me, that's why education is a big part of it, for them to understand why it's doing what they're doing and how they can get better.
So I think on that note, and we've flown through the hour. I'm sure we'll continue this conversation off air, but I just wanted to thank Shakil and Matt again for sharing their time. We usually have a system of 3 tips, but I just don't think we've got enough time. But thank you again. And Fahim, who's our next guest for next week?
Yeah, thank you again. So we've got Sebi, we've got a dentist, and hopefully we'll be doing a dental part 2 next week. He's a practicing dental surgeon in Huddersfield, so that would be really good for people who want to talk about teeth. And any questions, please bring them on. And just going back to what Matt said about pain, we are doing a pain issue with a consultant pain specialist and a clinical pharmacist with an interest in pain on our November 3rd issue. So we got all of this all boxed off as well, Matt. So, been a great evening. It's completely gone by, and hopefully it's been really educating experience and inspiration for people listening. Thank you so much, everyone.
Okay, thank you. Take care, everyone.
Yeah, thanks, guys.